undertook case studies in 4 international organisations that were working to improve integration. So they were trying to improve the coordination between different professional groups, teams and organisations and ensure that patients got better quality care and a more coordinated experience of care. And we wanted to look in particular at what helped them to do that and what hindered them. We used a combination of focused interviews and site visits, and then we also looked at some of the documents and reports that they'd produced to understand exactly how they went about improving integration. We wanted to look at the nitty-gritty of what they were doing, and also how the context in which they were operating, the policy, the regulation, the payment systems that were shaping the way that they worked, affected what they could do in terms of improving and coordinating care for patients. We wanted to choose a diverse group of organisations that were relatively early in their work to improve integration. We sought advice from a panel of around 20 expert advisors who have experience over many, many years about improving integration, researching and evaluating integrated care. And they pointed us towards a large number of organisations that they considered to be at the leading edge, that were doing the most interesting and innovative work. And we selected from within that group. But we were very clear that we didn't want to choose the usual suspects, the big integrated delivery systems like Kaiser that we already know quite a lot about. We wanted to focus instead on those that had characteristics a bit more in common with the NHS. So those that were working across multiple small providers in their communities, so a bit like our GP practices and trying to integrate across dispersed primary care. We wanted to look at organisations that had a population focus, that were trying to do things with whole populations, not just the people that walk through the door. And we also wanted to include an example of a health and social care programme. So the 4 organisations that we chose were a government-funded network in North Carolina in North America, which particularly wanted to improve access and quality of care for people insured through Medicaid, so that's the unemployed, homeless. The second organisation that we chose was also North American. It was called the Greater Rochester Independent Practice Association, and that's more like an umbrella organisation that provides both administrative support and clinical development support to 800 independently practising doctors in clinics in the community there. The third one was similar but based in Holland. It was called RHZ, and it was an umbrella organisation supporting all 89 GPs in the Maastricht area to deliver integrated care for chronic disease. And that was formed in response to a government policy to improve integration for chronic disease. And then the final organisation was the North Lanarkshire Health and Social Care Partnership, and that was a partnership between local government and the NHS in North Lanarkshire to deliver integrated care to 4 different care groups in the community there. Looking across all 6 organisations, there were a cluster of activities that we saw that we called integrative processes, and there were 6 broad groups, so organisational, clinical, informational, financial, normative and administrative. And what we noticed was that particularly there were some kind of synergies between them, that clusters of activities worked to support each other. So for example, the organisational arrangements, the governance systems that enabled them to identify areas where care is poorly provided, uncoordinated, not provided according to best practice guidance. They could identify those areas, and then they might develop clinical integrated processes to address them. Shared guidelines, case management arrangements, clinical prompts to make sure that best practice is delivered in a consultation. Then they would also arrange to have informational integrated processes, the delivery of data to different clinicians so they could see whether they were performing in line with best practice, point of care prompts that would remind them about things that needed doing. And at times, and not all the organisations did this, they would use financial micro-incentives to kind of align the prompts and make sure that clinicians did that. Now in Scotland, they didn't do that. They were absolutely adamant that financial micro-incentives were not the name of the game, and that it was professionalism and a real professional commitment to better practice that drove their staff to work collaboratively. So no one integrated process is essential, and you can have a workaround. So also in Scotland, they couldn't actually get their IT systems to work well. They had to create some slightly tricky information sharing arrangements as a kind of workaround to make sure that health and social care professionals could have some access to shared information. But in essence, they worked kind of synergistically to enable integration to take place, and then kind of wrapped around those integrated processes were the values and the organisational ethos that was about improving care, about coordinating services, very strong clinical leadership, and then the administrative support that meant that clinicians could focus on quality improvement rather than running their practices. The policy context was extremely important. In Holland, I mentioned there was a specific policy to promote integrated diabetes care, and it was that really triggered GPs to cluster into groups and start to work in a more coordinated way. In Scotland, Our Joint Futures policy was very much about developing a national vision for health and social care. And in North Lanarkshire, they had a strong tradition of collaborating, but this really pushed them, I think, to the next stage. And it was through senior leadership building on that policy that they carried on and developed this health and social care partnership. Payment systems were important. In the North American case in Rochester, it was changes in the way that insurers would pay for care and regulations that governed the way that doctors could work together that led them to develop this whole clinical integration program. And at times this could work against them. So for example, in the North Carolina example, very tight data governance regulations meant that they were trying to get shared care between different professional groups, but actually it was very, very difficult to do. They couldn't share the information that they needed to really provide a good coordinated service. So it could work in both ways, but broadly, a supportive policy and regulatory environment and a supportive finances are very important to get this working. After the policy pause, we are set up in some ways with a policy commitment and the opportunity to develop regulation and finances that will support integration, an apparent commitment to do that, but the devil will be in the detail. We need to be able to create ways of paying for services that encourage and incentivise different providers to work together. And that's a clear challenge for Monitor and for the National Commissioning Board. I think there is also a challenge to deliver practical support to organisations on the ground that want to do this. I've mentioned in terms of the integrated processes needing good IT, shared information, clinical support systems. It's a new way for professionals to work together in many cases. So actually just practical support about developing IT systems, about actually getting IT systems to talk to each other, about how to develop effective integrative governance. I think those kinds of practical support will be very important. And then for commissioners, I think it will be important that the work between health and wellbeing boards and clinical commissioning groups is really focused on promoting integration wherever possible and on developing new approaches to contracting and commissioning supported by the National Commissioning Board that will really create local drivers for different groups of clinicians to work together. Well, we've just seen a lot of mergers taking place between community services and either acute trusts or mental health trusts. So there are some newly merged, structurally integrated organisations that are coming onto the scene. And there's quite a lot of emphasis on networked service delivery. And I think the findings from the report about integrative processes and needing to get them to work together is equally relevant in both of those contexts. These are going to be new organisations, new networks, and if they're going to deliver truly integrated care, they need to think across that range of activities. They need to get each of those domains covered and working together if they really want to deliver better, more coordinated care for patients.